We're here today with Dr. Alex Mitchell, who heads up the Psycho-oncology department, to find out a little bit about what this department covers. Whereabouts are you based?
We're based in Leicester in the East Midlands.
Right.
And we try to provide a comprehensive psychological and psychiatric support service for patients with cancer.
Right.
It's a service that really is quite patchy, both nationally and internationally. We're quite lucky locally that we have a service that's been commissioned by the oncologists to provide care for patients. In other words, they're recognising the psychological and emotional needs of patients. And they're recognising that they can't just deal with all of those problems themselves without some specialist help.
Is this specialist help available all over the country, or is it?
Generally, no, I'm sorry to say. I mean, it's actually available in some places through psychology departments, some places through psychiatry departments, and some allied health professionals like social work colleagues. In the Scandinavian countries like Netherlands, Denmark, and also Sweden, they are very strong in looking at the rehabilitation side of cancer. And whereas we as a department, Psycho-oncology, is fitting under psychiatry, it does cause a slight issue because not all patients are comfortable with psychiatry.
I can understand.
In some ways, we'd be better with a Scandinavian model where we're under rehabilitation oncology, which is getting that patient back to the maximum degree of function after they've had their acute treatment.
I mean, it seems to me to be a very specialised sphere. It's not a generalised one. It's specific to cancer patients.
Yeah, I can see why you say that. It could be seen as a specialised area. But if you think about it, which cancer patients wouldn't be amenable to having a psychological or emotional issue helped? What patient is doing so well that they really don't need any help in that area? I mean, we do have the statistics on that, and there is a percentage of patients who really do seem to sail through their treatment and they don't have an emotional problem that they need help with. It is true that there are some very resilient people out there, but a lot of people, in all honesty, do need help. And there is a question whether cancer is something really different to the other medical areas where, let's say you had a stroke or had a heart attack. Shouldn't everybody have psychological and emotional help in those areas too? Yes, they should, but the difference with cancer is really that it's such a feared condition.
Yes.
In other words, you can actually be in remission from your cancer. Your oncologist or hematologist can say, we've treated you and the cancer is gone for now and your outlook is good. But emotionally, people in that situation can still be really struggling. They can basically be stuck emotionally, even though physically they've done really, really well. So there is something special about the fear of cancer and the fear of it coming back. And, that question that everybody has in the back of their mind, what's going to happen in the future?
And do you find with patients that it is very much an ongoing situation, that you'll have patients who perhaps were treated many years ago but still find they have need for support?
Yeah, I mean, initially I did think that it was all going to be just patients recently diagnosed. But you're right, people who've had cancer a long time ago do have needs as well. We've actually been studying that with several of the students recently, because what we found with the students, measuring through different studies that have been done worldwide, is that depression rates do actually diminish over time, time since the diagnosis, although they remain about the level that you'd find in primary care. So the level of depression in primary care is significant. On any one day, it's about 15% of consultations have a significant depression as part of that consultation. The person may or may not say that, but if you do a structured interview, you find that depression is there. Anxiety even more so. So, if we combine depression and anxiety, it is true that people a long time after the cancer have a significant concern. And of course, anxiety is the one, isn't it? That fear of what's going to happen in the future.
Yes.
And what we noticed from that worldwide literature was anxiety rates, as far as we could see, up to 10 years after the diagnosis, they never really came down to normal. They were always quite high. So it is definitely relevant to attend to those emotional issues, even a long time after the cancer.
And with regards to, I mean, there's a lot of literature obviously out there, but I believe that you're also setting up a video program which you feel could be very helpful to patients. Could you tell us a bit about that?
Well, I guess the premise there is what is it that patients really want and benefit from? And I think my starting position is perhaps one where all clinicians start, which is we start with modalities or treatments that we think are going to help. We almost impose it on the patient sometime. So let's take a kind of extreme example. You know, a psychiatrist or GP might want to prescribe a medication, an antidepressant, for a patient, and that's not inappropriate. It's sometimes warranted, and patients often do well from that. But if you ask patients in a more open way, what intervention would you like for your emotional distress or your anxiety? Actually, antidepressant or anti-anxiety medication is one of the least favoured options. So that, you know, should get us thinking as clinicians, are we offering the right things, and are we offering treatments that are fully acceptable to patients? Because at the end of the day, the power of the treatment is only partly in how well it works. It's actually partly in how acceptable it is. And if people don't like the treatment, it doesn't matter how effective it is. If you're not taking it, or it has side effects, it's not going to be actually effective in clinical practice. So this is a new stream of innovations that we're trying to develop, which are actually highly acceptable and actually use the power of other patients. And that's something that many clinicians will already know, that, you know, if you look at the effect of group therapy or drop-in group or mentorship or buddying system, all of those are surprisingly powerful. And they have a variable input from clinical staff, but actually that's because the power is in the meaning of meeting other patients, the fact that other patients have been through something similar to you, and you can identify with them. Plus, they actually have their own experience of what helped them and sometimes what harmed them. I mean, we're allowed to say, you know, what didn't work for you. Tell me about that. So the problem there then is accessibility. How do you spread that power of other patients across new patients and even patients you haven't seen yet in the future? In clinical practice, we tend to have quite a narrow model. In other words, we tend to work around a kind of consultation model. The patient comes in, you're in the clinic, they tell you their problem, you try and help them, they go away, they come back next time. That going away and coming back next time is quite an issue, because that's actually most of the time. Most of the time the patient's not with me, they're at home with their family or on their own. So something that's going to work outside of the hospital is going to be arguably more powerful, or at least more systemic than one that works just in the clinic. Of course, some of our older interventions were there to take away, but in reality they're not really monitored. And in that old-fashioned model, if you like, I'm in control, aren't I? And with the best will in the world, it's only going to be the number of people I see that could be helped. So a more powerful model, I think, is to come up with an intervention that's widely available and that, to be honest, I'm not in control of. Now, there is an issue there for organisations that if my employer asks me, well, how many contacts have you had? And I'm saying, well, I've given this self-help material to 100 patients, they're not going to be that impressed because they're not getting the credit for it. And that's an issue for organisations and employers right now.
But surely the ongoing health and well-being of cancer patients is the primary objective.
I agree with you, and I think we should all be doing as much as possible for the community as a whole, which is another reason why things like teaching and research are important. It's not just what you're doing locally, it's a form of dissemination so that other people can benefit from your work and ultimately patients can benefit. The video diary is actually the latest innovation that we're developing here. The video diary gets around this problem of kind of the group therapy only being available for those that can attend on that day at that time. And the video diary essentially is a recording of real patients' accounts onto video with their permission. And that video is edited for their own purposes. In other words, so that their account is meaningful for them personally initially. So they have their own copy. That sometimes that's as far as some people want to go. They want to give their story as a first-hand account, but they want to keep it for themselves or their family. And that's absolutely fine. That is definitely therapeutic. But most patients actually are happy to go further than that and allow their story to be given out more generally to new patients, or in the future, patients that we haven't seen yet that are going to come in the future. Now there's a question, isn't it, about dissemination. How do you make that available to the most people as possible that might benefit from it? Now, at the moment, what we're doing is a kind of hybrid of the old model and the new innovation, which is we record the patient stories, and when the patient gives the permission, we have a DVD master that they're happy with. We keep that master copy, and when new patients come who have a similar condition, we offer to give that story on DVD to new patients. And new patients then can watch, let's say, somebody with a hematological condition like myeloma. It's a relatively unusual, hematological cancer. Yeah. But if they can hear on the video that they're not the only one with that condition, then they will be able to get a lot of benefit from that. And it's not just limited to one account. We might give them several accounts. So the dissemination is initially in that kind of hybrid where we're giving out the DVD-based stories. And we want to improve that by getting the hospitals around the country to actually have the DVD bank available in the support centres like Macmillan Support Centre, so that patients who come for information don't just don't just get information, but they get something more meaningful, like obviously the video account.
So there are various ways of letting people see the film, whether it be personal or to other patients. Have you thought about actually using the internet as well?
Well, that's really where we're looking to develop things now, and there are some problems with internet dissemination, which is mainly that we relinquish control and then we're not really monitoring who's logging in. Now, on one level, that's probably good, because anyone who finds these interesting or potentially useful could log in and hear the stories, and it could be even in different countries or different time zones. It wouldn't be conditional upon me giving out these DVDs. So definitely the internet is powerful. The problem, I guess, is one of the permission. We have to be careful that the patients are giving us permission to release that information. Now, I haven't actually come across anyone who is really worried about the internet as a form of dissemination yet. Patients have surprised me how much they are willing to let their stories be out there. So far we haven't run into a problem, but I am mindful of the fact that we have to be careful about that. And I'm looking into the options for password protecting either the site or individual videos. And it could be down to the patient level of protection. Like, for example, a patient might say, I prefer my video not to be released to the general public, but I'm happy for it to be in the hospital setting, for example.
I understand.
We were looking into this right now. But yes, the internet is obviously incredibly powerful. And ultimately, I think that's where the real influence of this program on the well-being of the community as a whole will come.
And surely with the films being out there, isn't it a case that anybody anywhere can then benefit from it rather than...
Definitely. And I mean, one really tricky question is, would it have to be just cancer patients who benefit? Now initially you think, well yeah, that's what the program is designed for. Why is he saying not cancer patients? But what about relatives? What about caregivers? What about people who've had cancer 10, 20 years ago, who on paper they're not really a cancer patient now? They would consider themselves as long since beaten that condition. It's a memory for them, albeit one that's still poignant. So yes, I think other people who aren't necessarily those we'd immediately think would benefit could actually get quite a lot from this program.
And would the videos be linked to a cancer site? Would that be the way forward?
I think in principle, yes, they'll be badged as linked to a cancer site rather than free floating.
That's what I was
you
thinking.
could upload them just onto a video server, which there's many online right now. But they become, it loses a little bit of value in quality if you just upload individual videos here and there. What we want to do is collect them all together, and they will be labelled by certainly by type of cancer, so that people can log in. Because the natural thing to do is, if you have, let's say, prostate cancer, you want to hear that story first, don't you?
Yes.
So we definitely go towards our own site initially.
And have you found that patients who've seen these films have related very much to their own personal experience, and it
Definitely.
has definitely been beneficial to
Definitely.
people you've spoken to.
Definitely. I mean, it has surprised me how powerful this has been. Okay, we haven't disseminated yet via the internet, but just on our own clinical judgment, our impression is that the patients who do the video actually benefit, but those that receive the video really benefit. And nearly everyone who's received a video has been curious to watch more videos. Because the interesting thing is, you probably would gravitate to your own condition initially and have a look at that, but you then tend to expand, I found, to other areas where patients think, well, that's somebody who I can identify with because, they're my age, let's say. So I'll look at that one. And it doesn't have to be your condition. Sometimes having a life-threatening condition is all that you need in common for you to see the common threads there.
Yes, I can understand that. And also I was thinking, when you read something, the written word is not as powerful. There's a lot of information out there for people, but to actually visually see something is a different thing. You take it on a more personal level.
I agree, and in fact our predecessor of the video program was a written diary, which is still effective and still useful, because that was better than just third-party material which wasn't personalised.
No.
Having the personalised information, albeit in a written form, was definitely an advantage, but it was improved again by having it on video. I mean, I do think there's an improvement on the video, and that is having your own mentor or friend who's been through it, who is actually available to you anytime. And some people are very lucky to make those contacts in hospital, and they form those relationships, and then they have that kind of therapeutic bond, don't they, through the cancer journey. But I have to say, we don't, for some reason, facilitate that in any structured way. So it's kind of ad hoc whether patients get that option. So this is a way of saying, I can't promise you your own cancer friend. I wish I could. But instead of that, what I can do for you is provide you these video stories, which are real stories of real patients. They're not made up.
And with regards to things like drop-in centres and where people can meet and exchange stories, is that something else on the psycho-oncology side that you think would be beneficial?
I mean, that's something that has been pioneered elsewhere.
I believe so, yes.
In fact, in Hull, they have a very good system where anybody coming for chemotherapy or radiotherapy is able to drop in to their centre and have relatively informal support from other patients and from staff if needed. And having visited that centre, I do realise that a drop-in system is very useful. And really, one of the pointers to me that it was valuable was when we've run group therapy in the past. We've run a kind of medical group therapy where I give the sessions or a colleague, and then the sessions run, let's say, for 8 or 16 weeks, and then that group comes to an end. What I found was patients didn't want to be discharged at the end.
I can understand.
Because they were going to lose that contact. It wasn't really with us, it was with the other patients.
Yes.
So that's where drop-in actually picks up, where group therapy tends to stop, which is continuity of care.
And do you think that there is a place in the psycho-oncology section for phone contact to patients? Do you find that patients who've been on your books like the idea of someone phoning them on a fairly regular basis to just check in on how they are? And is that facility available?
We do have that. We developed that last year. We call that telephone outreach. There's two sides to that, which is, should we be making contact with patients more regularly by phone rather than making these formal appointments? And I think there is an advantage in that, because the patient still knows that you're interested if you make a call. And you can do that much more regularly than you can scheduling clinic appointments, and it's more convenient. Now there's another side, which is, does the patient want to ring us? And we use the telephone as a form of almost advice line where the patients can ring. Now in most clinical services, any patients can ring any time, but we specifically invite them to ring. We send them a formal letter saying we are open to receiving calls from you. We actually make it kind of clinic based or slot based, so we're available to take those calls on a certain day of the week. Now the advantage of that is then the patient has less reticence to ring. They feel they can ring any time. what tends to happen if you don't have that is patients will only ring in a kind of dire straits.
Yes.
Or they'll save their problem for the clinic, and that could be a very long wait. So having the telephone option, I think, is a very good backup. There is one slight counter to that, which is, again, at the organisational level. Your employer might say, well, so what have you done this morning? And I might say, well, I've received 10 telephone calls. Well, the employer might say, well, I'm not very impressed with that. You know, you should be going to see patients face to face. That's where we can sometimes have a mismatch between what the employer wants, which is generally contacts, because they can bill for that, not necessarily that we get the money for the billing, but the hospital will receive some money in the future based on the number of contacts. That's the way the NHS is kind of pointing towards, yeah.
But I would think the benefits of regular contact by phone would outweigh any of the monetary side of things.
I would definitely say yes. It's something that I would recommend all services consider. The other slight advantage, on a kind of more selfish note, is that if you using the clinic-based system, having a telephone reminder for who's due to come the next day, so the patients are just asked, you know, are you okay to attend tomorrow, can be very advantageous, because with an physically unwell group, the missed appointment rate can be really very high, sometimes above 30%, whereas in mental health the average is 20%, and in medical settings 10%, and in elderly group 5%. We've got this whole spectrum. There's a big difference between 5% missed appointments and 33% or 30%, which it can be in a medically unwell group with a mental health problem as well. So one very easy way to reduce that down to less than 15% is to make those calls in advance, at least, you know, such as the day before the appointment. So yes, I think we can do more using the telephone than we imagine, and I think patients do appreciate that.
The other thing that I was thinking, that written literature tends to always be very positive because you don't write down a lot of negative things, whereas it appears to me that patients going through various situations don't want to feel they're the only one with a negative feeling. And I believe with the videos you encourage people to be honest on the good, the bad and the ugly, so to speak.
Yes, I mean, I personally have a slight dilemma about that. And that's been kind of backed up by feedback from other clinicians. Imagine a situation where the patient's not happy with the treatment they've had for whatever reason. There could have been a delay, a mistake, you know. These things do happen in any healthcare setting. Now the patient feels it's somewhat cathartic to express that problem to somebody else, particularly if you're going to help them further do something about it. Although, you know, patients don't always want to make a complaint. They might just be wanting to say, this happened. Now on the video, they often want to say, you know, this happened too. And I think, as you're implying, other patients who may be subject to the odd mistake and error would actually find that beneficial rather than harmful to know they're not the only one. Of course, mistakes are still uncommon compared to the number of correct interventions or therapeutic alliances that are made. So I don't want to panic people and saying it's all about, you know, negative stories. But what I would say is, in my example where that person's had that delay or error, then they record it to DVD. We often will send the clinician a copy to say, you know, your patient came in and if you're interested, this is the story they gave. And many clinicians respond positively to that. But there is an issue then if the clinician is the one that is subject to the error, if you see what I mean. If they were involved in that error, sometimes they will feel badly that, oh, you've highlighted a mistake and now everyone can see. Now my personal view is I think patients should feel free to be honest as they want to. I'm just a bit cautious about how to give that feedback to clinicians. If patients haven't mentioned anything and then you send them a report that says, you know, there's been a problem, sometimes the clinician doesn't like it, of course. But I hope in the grand scheme of things, everyone will see these as a learning experience, both for us as clinicians, because we can get really valuable information from what patients say, but also other patients. That's the primary aim, that they will get great benefit from what other people have been through. And you know, thousands of people are going through the system every day, aren't they? And we're not tapping into that as a resource as much as we would like. And I think this kind of video program will really take off in the future.
From what I've learnt from speaking to patients who have participated, it appears to me that at the end of their treatment, it's then that they have the problem with the ongoing situation. Everything's finished, I've had my treatment, it's all over, but I still feel rubbish some days.
Yeah.
And that's when they seem to need the help a lot more than they're aware it's out there.
Well, what you're highlighting there is this gulf between the acute medical model and the rehabilitation model.
Yes.
This acute medical model is the one that we can never dispense with, because otherwise there's no care.
Yes.
But having said that, what we tend to forget, particularly in the climate of cuts and cutbacks, is that there's more than just the acute treatment.
Definitely.
The acute treatment just gets you back to having potential to do what you were doing before. It doesn't actually help you get there. And what we've relied on too much, in my opinion, is the patient just using their own motivation and drive to get back to, as much as they can, as close as they can in terms of where they were at prior to their diagnosis. In other words, we've relied on the patient being the driver in the rehabilitation phase. And I don't think that's the correct or fair way to do things. I think that should be classified as part of the medical process, part of the cancer journey, part of the medical journey. And I think that clinicians should help patients in that rehabilitation phase. And as I said earlier, that is actually a core part of oncology treatment in many Scandinavian countries, and it's very impressive when you see it. And really, the psychosocial area should fit nicely into that, because we are, in many ways, a rate-limiting step in terms of what patients are able to do subsequently. To put it in black and white terms, so let's think of the example of a patient who's not able to get back to their previous degree of functioning because of the illness. Now, many patients, this could easily be, you could easily be me, anyone, could think, well, I can't do my previous goals and objectives, therefore what's the point being around now? What's the point trying with anything? Because my previous interests are almost like wiped out, and my work isn't available. I can't do that. So I don't see anything valuable in my life, because what's happened is the objectives and the responsibilities and the roles have all been pulled out like the rug underneath, haven't they?
Yes.
And what our job is to really say to patients, look, obviously I'll try and help you with the physical rehabilitation with my colleagues who are working with that as much as possible. But even beyond that, even if you're limited, why don't we see what you can do? Why don't we see what you can achieve? You might surprise yourself by what you can achieve. Maybe there's new areas of interest. Maybe if you started something new that you've never done before, that would be meaningful and fulfilling for you. And maybe there's roles that you can do in life that weren't your previous job, but still a responsibility that you feel is meaningful in terms of giving back to others. And that's really the rehabilitation model that we try and work with.
And were you saying in Scandinavian countries they don't term it psycho-oncology, they have a different terminology?
Well, they call that whole phase rehabilitation oncology.
Which is what it is.
Yeah. Psycho-oncology would be a small part of rehabilitation oncology.
Of the whole thing.
And they actually have training in rehabilitation oncology, and it would be very much multidisciplinary. It wouldn't just be psychiatrists, it would be also psychologists, yes, it would be social workers, physiotherapists. I was speaking to a really interesting physiotherapy colleague who was working with patients looking at fatigue and how to combat their fatigue after the cancer.
Because that's a very major issue.
Definitely.
Yes.
But where does the psychological side of fatigue come and have an impact on fatigue? And where does goal setting and where does exercise as a form of treatment for fatigue fit in? This is something that we might think, well, doesn't that harm the situation? But it actually helps the situation. Studies are beginning to come out now showing that exercise as an intervention is actually very therapeutic after a cancer diagnosis.
Yes, because you can very easily get into a rut and think, oh, I can't be bothered, or I can't do that, or I'm tired, and then it becomes a routine. Whereas sometimes forcing yourself to do something and getting out there is the very best thing you could be doing. patient is in hospital undergoing various treatments, how aware do you think they are of psycho-oncology and how helpful it may prove to be to them personally? Is it something that is readily publicised as well as being available, do you feel?
I mean, that really depends on the local hospital and what work that team is doing. I mean, definitely we have a major educational role for our colleagues. So if you look at the size of our team, which is really very tiny, it's in terms of paid staff, it's just myself, 2 nurses and our secretary, although we have a lot of affiliated students and researchers and that kind of thing. But in terms of the core paid clinical staff, it's a very tiny team. Now, we have a major role in making sure those frontline cancer clinicians, particularly the clinical nurse specialists, because they really provide the hands-on treatment with those patients, particularly around that critical time of discharge from hospital. So, which we really try and promote our service with those clinical nurse specialists. And the way we do that is we try to form a one-to-one relationship with them. So let's say you're a breast care nurse. I want you to know that our nurse here is available to ask you questions or answer questions from you and vice versa. You know, we basically try to provide support and encouragement for those frontline cancer clinicians, and we actually do that via a monthly supervision group for them. Now, they also have to be willing to attend that, and they have to be a little bit interested in the psychological area themselves, but you can actually help your own cause by allowing them to discuss problem patients that they're stuck with. And nearly always the psychological, emotional side comes up anyway. So we definitely do a lot of promotion and education. I'm not saying we couldn't do more. We definitely could do more. But I think you're almost asking about the bigger picture, like, you know, nationally, is it really known, or in other centres? And I would say yes, it's not very well known. It's an area that is not well promoted, and as a result of that, patients can suffer by not knowing there's a service available, even when there is a service. You see, patients can often get help through, let's say, more old-fashioned but conventional routes, even if psycho-oncology isn't there, such as referral to other colleagues in psychology or psychiatry who might help. But if you always rely on that referral model, which is the clinician recognises the problem in the patient agrees, they then send a referral to their clinician colleague in mental health or psychology. They then screen it, decide if it's important or pressing, invite the patient to come, perhaps to a psychiatric centre or psychology centre where it's outside of their routine, setting, outside of the medical hospital in many cases. That creates a certain stigma for patients, and then the patient starts to think, why I don't have a mental health problem, why do I have to attend? And this is when you start to run into problems with a lot of patients not turning up and suffering, unfortunately, in near silence, because we're not responding to their needs, or to put it another way, we're not packaging the care in a way that's acceptable to them and most available either.
Would it not be a good idea at the actual hospital level, when patients are undergoing radiotherapy, chemotherapy, if there wasn't regularly somebody around who say, it's very normal to get a bit down, after everything that's going on, this is what we provide, why don't you give it a try, it's very normal. Because I think this is probably a problem that most patients don't want to feel they're different, and if they feel everybody else feels the same. And I think the word psychology, as you say, they think, oh, well, there's nothing wrong with me, but it's a normal feeling after a cancer treatment.
I totally agree.
It's the normality that you want to sort of explain.
So what we're really doing there is to try to normalise their experience, including their bad experience.
Absolutely.
Not that they always have to feel well. A bad experience can be expected. It can be statistically normal, but nevertheless, you are allowed to receive help for that. And that's so much the case with so many things that we take for granted. That doesn't need to be any different for psychological or psycho-oncology help. We should make those things acceptable too. So yes, we should have a way of saying to all the patients on the front line, we're available if you need us. And the way we actually do that here is we do it via a simple booklet or simple handout for patients that says we're actually very down-to-earth service, we're available. There's various modalities of treatment. If you want to receive our input, by all means ask. But as a backup to that, because that's just written information, isn't it? As a backup to that, the clinicians on the front line also have to kind of promote our cause by saying to anyone who's suitably worried, depressed, angry, or having other problems like cognitive problems, that I know a team that can help you, and this team it's maybe sounds like this is not part of your routine care, but it really is for many patients. And this is a very down to earth team working in the emotional side. If you're agreeable, I'd like to make a referral, and I know they've helped a lot of patients who've been in your situation before, and they really won't make you feel on edge or like a stranger. You'll be welcomed by that team. So if they make us seem acceptable and friendly, then obviously the system works better, doesn't it? And patients turn up, and we get better trust with that patient from an earlier stage, and the trust between the patient and their provider, the patient and their clinician, that's so critical in many areas of medicine, but particularly in the psychological and psychiatric domain.
I've always been interested with any form of cancer, when a patient has actually finished treatment, everything's gone ahead. Is there any other follow-up treatment 6 months down the line, a year down the line, 18 months, to just one person? How are you feeling now? Does that ever happen? Or has it always got to be the person saying, I've got a problem?
Yeah.
Because I think with a lot of people, if they were contacted after their treatment, probably a year down the line, they would be thrilled to bits to hear that there was somebody out there that actually cared still. Because I still feel that with cancer, it is an ongoing thing you've lived with. And even if you've beaten it, it's still going to be in your system psychologically. It's nice to think there's someone out there.
Well, let's give those clinicians who are following up patients some credit that they do often ask how the patient is, particularly when it's a non-pressurized, non-clinic based appointment. In other words, those clinical nurse specialists who do a follow-up, an extended follow-up, in the community or over the phone sometimes, yes, they will ask those kind of questions much of the time. However, when we invite patients back for like screening appointments or check-up appointments on their cancer staging, the patient's very anxious to get that information that it's all clear.
Yes.
And we tend to forget about the emotional side, and everything becomes a medical appointment. And I can understand why, but that's when those questions tend not to be asked. You asked there about the question about how are you feeling, and we actually have been looking at the data for what do clinicians say during the consultation. And it's quite interesting that the medical teams often prefer to stick with medical questions.
Yes.
And they often have medical jargon as well, which doesn't necessarily help. And sometimes I do wonder whether that's almost a package to suit us as clinicians, that it keeps the consultation focused and simple on our agenda. But the patient has an agenda too, which is a broad agenda. It's not just psychological and emotional domains. It's any unmet need. But the clinicians need to think about that in terms of which of those unmet needs are meetable. Because which ones can they address? Because that's really our job, to address directly or by referral or assistance meetable unmet needs. Now, we can actually look at the data from other studies on how much are emotional areas asked about, or as you said, how much is it just relying on the patient to mention a problem. And when we surveyed clinicians nationwide actually about their cancer discussion preferences for psychological and emotional issues, about a quarter said on most occasions I would just leave it to the patient to mention that kind of concern because my agenda is elsewhere. About 3/4 said they would ask those kind of questions, but not necessarily routinely every time. Just if they were worried, the patient's tearful, oh, I should ask. If they get a prompt, if you see what I mean. And then regarding the actual type of questions, most clinicians are not entirely sure what to ask. But your question about how are you feeling right now, that's actually a very good starting question. It's a broadly acceptable question. You don't need to necessarily say, as a starting question, how depressed are you today?
No.
Or do you feel like life's not worth living? Those are in-depth questions if those broader questions are positive. And most clinicians know that. You start with something that's information gathering and acceptable to the patient before going into those detailed, potentially sensitive psychological questions.
Well, a lot of patients have to go, don't they, annually for a check, or maybe for 5 years plus. And to my knowledge, when they go for these type of annual checkups, they are very much clinically assessed. I have never heard of anyone who's been asked how they actually feel.
Not as a systematic check. Now, we're actually improving on that system by having a screening technique, which is just another medical jargon term for making sure questions are asked.
Yes.
But you perhaps decide in advance what those questions are. And it doesn't always have to be the interviewer asking the question or the clinician asking the question. The patient can self-report their items and say, I'm struggling with these areas. So we've been studying a screening project in Leicester for actually 2 or 3 years now, and we approached about 500 patients who completed a screening assessment with their frontline cancer nurse. It was actually the chemotherapy nurse or the treatment radiographer. And the screening program was valuable to enhance the communication between the clinician and the patient. It was also valuable to confirm to the clinician who wasn't depressed or anxious, because they actually have some uncertainty about who is and who isn't.
Yes, because people mask their situation.
Yes, so you can say, you could have a consultation where the patient comes in, you have a medical agenda, the patient doesn't say very much. You couldn't say whether they were really distressed, you haven't really elicited it. So the screening project actually improved by, it's going to sound like a small percentage, but 17%, the ability to rule out the problem if it wasn't there, which is actually was quite powerful. It was very significant in the analysis, but it actually didn't help them that much in confirming who was depressed or distressed or anxious. The clinician would answer that the reason why it didn't really help is because in 1/3 of people the person was clearly upset and the clinician spotted that. In 1/3 of people, they were really well. They were like that resilient group we talked about earlier. And the clinicians would say, I didn't need to really ask them detailed questions. They were doing so well. It was just that middle third where it was uncertain. And in that middle third, it helped a little bit, but it didn't help as much as we thought. So overall, the screening tool actually did more than enhance detections, as we would call it. It enhanced communication, and it may enhance a little bit referral, which is when do they decide that they need our help? That's when they ask for further input. It may have helped that area as well. So screening can actually be disseminated in different hospitals, in different stages, different settings. There's a big push for screening right now, but it's one of those areas where, because it does take extra time, not every clinician is in favour of it. And ultimately, of course, we have to prove, like any intervention, it really does work. Otherwise, we're just asking questions
for the sake
of it.
Yes. That's a lot of food for thought. I can understand that it's a very wide area, and I think anyone watching this will have learnt quite a lot on the sphere that you are specialising in. So thank you very much for coming in and talking to us today.
My pleasure.